All right, now you want to take us through, Dan, about the real fundamentals, the nitty gritty of what constitutes this advanced monitoring we're talking about to help improve and standardize the care of our patients.
Yeah, thanks, Seenu. So, I think, thus far we've really tried to make the case that, this is an important thing for us to do. And I hope by this point, in the day and in kind of the conference that you're all with us on this. This is, being targeted, being physiologic, acting quickly, being protocolized. All of those things are really important. But now we're going to talk about the how. How do we do this in a way that makes sense? And what are the fundamentals of really this advanced monitoring that we're talking about? And what does that entail? What does it look like? How do we target physiology as we transition from a preoperative patient, a beating heart, a heart on bypass, coming off bypass, transitioning to the ICU, coming out of the ICU? What does that look like, and what is that continuum of care? So for the next few minutes, that's really what we're going to touch on. So we're going to start with the basics. I love physiology. I could talk about physiology all day. And when we really think about what it is that we're doing in the ICU, and this is why I kind of geek out and get excited about these ICU patients, is we have control of everything. We get to learn about anything we want to learn about these patients. And, as kind of baby interns, we learn that, okay, we're going to look at the blood pressure and the heart rate. We're going to start there. But really, there's a lot more that we can know, right? We can look at their physical exam. We can look at their urine output, kind of how much urine they're making per hour. We can now dial that in even further. We can look at kind of static pressures like a CVP, a PA pressure. We can look at cardiac function. We can look at their output, their index. We can look at tissue level oximetry. So we've got all these tools at our disposal that we can be using together in concert to really understand the patient. And if we understand the patient in front of us, then we can make evidence-based, kind of individualized, but protocolized decisions. And that's really what we're after here. So we can go to the next slide. So I believe, and I think the data is increasingly showing us that hemodynamic monitoring can aid our assessment of really this holy grail, which is tissue level oxygenation, right? When we think about what we're trying to do, yes, we want blood to move, but why? Well, we want the blood to move to carry that ever vital oxygen, the ATP, to the cells, so we can make ATP and nothing gets disturbed through these wild physiologic swings. So, with our hemodynamic monitoring, what we want to do is not only look at the pressure, okay, that's one way to look at the world, but we need to look at pressure, combine that with flow or output, and then also look at kind of resistance, the SVR, if you will, or the pulmonary vascular resistance, if we're thinking about the pulmonary bed. So that allows us to detect perturbations or problems really early. And then we can also dial in, our interventions with a lot of finesse here. So when we think about, this kind of goes back to one of those early physiology textbooks, but I think that those of us that do cardiac medicine with a good deal of frequency are thinking this in the background all the time. So really what we are always balancing is this mix between oxygen delivery on the one hand and oxygen consumption on the other. And as we troubleshoot in the ICU, really what we've got to do is optimize what we can optimize, okay? We want to be adjusting what we can adjust. So, sometimes the heart rate's low. We've all seen that medical patient and we think, well, goodness, this patient's in shock because their heart rate's 35. Okay, that's really easy. I need to get a pacing wire in, or I need to, give them a medicine to increase their heart rate. And then all of a sudden things get better. Sometimes it's the stroke volume or the pump itself is not good. Okay, again, in the heart world, in the cardiac world, we see that all the time. These terrible hearts, how are we going to help that heart limp along? Can we give an inotrope? What can we do to support the heart? Sometimes it's bleeding or, the hemoglobin's low. Sometimes it's the actual oxygenation. We see, as a pulmonologist and kind of critical care trained doc, I see that all the time. So as we're thinking through this, we want to be figuring out where the problem is and kind of constantly adjusting our strategy here to try to improve, tissue level perfusion. You can move to the next slide. So again, kind of going back to 101 here, the determinants of cardiac output. Cardiac output equals heart rate times stroke volume, right? We learned that as medical students and, in nursing school early on. But really that kind of stroke volume, the ability to generate the optimal stroke volume is a lot goes into that. It's the preload. How full is the heart? It's the contractility. How well can it squeeze? Are there myocytes that work? And, what is the afterload, or that kind of the load on the heart when it tries to eject? And, when we kind of come back and think about this clinically, that's the physiology. Well, we know we're trying to target this, golden cardiac index of, above 2.5. If all of our patients had cardiac indices of greater than 2.5 coming out of the OR, Seenu would be a happy man. Like that's great. But we know that we're dealing with patients who live in this kind of chronic cardiogenic shock state sometimes. But, as we carry this physiology to the bedside, what does that look like? Well, in that row of red boxes down at the bottom there that you see, that preload is really the fluid and bleeding part of this, okay? So even though I'm not saying preload all the time, I'm thinking, do they need more fluid? Is that really what I'm after here? And how do I know that? If I'm making the decision to get fluid, how and why? Is it an afterload problem? Do I have vasoplegia? We see that a lot coming off pump, right? The vascular tone just isn't as good as we want it to be. Do we need to add pressors or do something else to get that vascular tone better? And then we also think about the contractility. Some of it's just the stunned heart, okay? Some of it is, we can look at the TEE intra-op and kind of understand that our heart is just a little sluggish coming off. And, that we understand that those are issues. So kind of all along the way, we want to be targeted with our physiology. And, I think this slide does a great job of, what we can do here is, yes, we can understand the physiology, but we can also touch directly on pathobiology that we see in the ICU. Move to the next slide. So what is fluid responsiveness? Okay. And again, I think this is probably a 101 topic for most of us. But, for the longest time, and I made this, I'll call it a mistake, but I had this misconception, I think, as an intern. I would get a call on the phone. The nurse would say, hey, the patient's hypotensive. And my answer was always, give them 500 cc's of fluid and I'll be right there. And sometimes I got there, sometimes I didn't. And I gave patients buckets and buckets and buckets of fluid. And sometimes I'm pretty sure I weaponized that fluid. I turned that fluid into an absolute weapon. So I'd come by the next day and I've got 4+ pitting edema. And I'm like, you're going to have to explain this to someone on rounds, because what did I do? This is a challenge, I think that we've all done. And it's really about shifting a paradigm. I want to give fluid to the right patients, but I want to give fluid if they're fluid responsive. And really what we are looking at on this kind of Frank Starling curve here is that when I give my fluid, I want to see a change in the stroke volume, meaning I want that fluid to do something good for that heart, good for that perfusion, good for that blood pressure, and ultimately good for that tissue level perfusion. So, do you have any thoughts about this? I think this is kind of the dogma. Medicine and surgery has struggled with this, jointly over the years.
It's a great point, and I think you're exactly right. Another important concept is to understand that the fluid that you give, only a component of is going to stay intravascular depending on what patient type you're giving it to. As we mentioned earlier, some of our patients are malnourished, they're cachectic, they have poor tissue albumin levels already going into surgery. So you really hit the nail on the head is about fluid responsiveness. There's some patients, the fluid you give can either just immediately third space. There are others that have probably some inflammatory process. They're really not keeping it intravascular. And there are others that they have reached that endpoint on the Frank Starling curve where the fluid is no longer going to help them, but actually harm them. So
yeah, and it's a great point. We've all seen that we've all seen that patient. I've done a bunch of pulmonary hypertension work, thinking about the RVs in particular, and fluid is a dangerous thing for a patient with a bad RV. You give too much and all of a sudden you're in big trouble. So, understanding where they are on this curve and kind of beginning to make up your own curve for this patient as you're caring for them really is where the art of this comes in. How are we going to do this? Well, there's a lot of different models out there. We're going to be kind of talking through one or a couple of different models for making decisions. But really, I think most of us are still going to begin with some sort of fluid challenge for the patient who is hypotensive or who is not, having, kind of the markers of perfusion that we would hope to see. And the reality is most patients, as they come off pump or come out of a cardiac surgery, are going to be a little bit dry, are going to be, intravascularly on the dry side. They're getting product back as they're rolling from the OR to the ICU. And so what we want to see, though, is that as we're giving this fluid, as we're giving the cell saver back, as we're transfusing product in some cases, that our markers of perfusion are improving. that our fluid status is changing, as we're giving fluid, that our stroke volume is improving. So what we're going to do is kind of continuously be testing and retesting this hypothesis. So as we give fluid, we should see on a patient who is monitored a stroke volume increase, okay? So the first is that we can give that fluid challenge, and we can see the stroke volume come up. Move to the next slide. So the other way that we can do this in a patient who, maybe you've already given a fair bit of fluid to, is we can use a passive leg raise. And, in our ICU, I will occasionally walk around and I will do just this. If a patient's still asleep on the ventilator, I will pick up their legs and lift them in the air and just give it, hold them there for 30, 45 seconds. And you can actually see it's like a bolus of fluid rushing from the venous system of the legs down into the heart. And in patients who are fluid responsive, you will see a very nice bump in the stroke volume. So very simple things that we can do, physiology 101 here, but it's nice that we can now begin to see that. That's something we've done for decades, but now we can see it in these unstable patients. We can see that stroke volume come up through our hemodynamic monitors.
And I think you're exactly right. You can see it in that continuous fashion, whereas before we would have had to shot a thermodilution before, then a thermodilution afterwards. Here you're kind of seeing it right there visually in front of your eyes.
Perfect. Yeah. Okay. So we're going to kind of assess fluid responsiveness with stroke volume variation. This is something that we can, begin to think about here. And so in the mechanically ventilated patient who's not breathing, all that spontaneously, we can look at the changes in the stroke volume. Okay. And this isn't for every patient, but we did want to mention this. If you look at this variability across the ventilatory cycle, okay, if you're seeing these swings in the hemodynamics up and down, that should trigger your mind to think about, why is that occurring? Well, as intrathoracic pressures changed, okay, those intrathoracic pressures, go up and down, that impacts right ventricular, or really biventricular filling, okay? As the pressure goes up in the chest, there's less blood in the heart, okay? And as the pressure releases out of the chest, there's a little bit more filling, okay, that we can see in the heart. And so that stroke volume variation, if it's less than about 9%, the patient's unlikely to respond to additional fluids. However, if we're seeing a lot of variability in, with the respiratory cycle, then that patient's much more likely to be fluid responsive. So just wanted to throw that out there. That's not for all your patients, but, I think we can use that in a subset who are still pretty deeply sedated with some reliability.
Hey, Dan, can you talk to a couple of maybe the loading conditions that need to be met in order to use SVV? I think that's a common area of concern of maybe overutilization of the parameter. Yeah, so
it's a great point. So, we talked a lot about stroke volume, but really this variability, you need to have a patient who's either still paralyzed or very deeply sedated with a high sensitivity specificity. If the chest is open, that will impact things obviously as well. So you just want to make sure that you're using this on the right patient. Seenu, I don't know if you have other thoughts about that, about when to use this, or, red flags to watch out for, but those are the two that I think of most commonly.
I think you're exactly right. We're also kind of creeping into the world of hypotension, predictive indices and things that are on the kind of cusp, and we can get into it at a later time, but really that variation is important to track, and understanding that when you have great variations in stroke volume, that's your ideal patient that is, and you really recognize them clinically by that's your roller coaster patient, right? That's the one that tends to transition from hypertensive to hypotensive. And the other example is that I was going to tease you earlier when you said bleeding. I said, heart surgeons, we don't have any bleeding.
Right, there's never bleeding, right?
That's the other time that that my kind of hair on the back of my neck goes off, is when I see great variations in blood pressure, patients getting normotensive and then suddenly hypotensive. So in my mind, there are basically two things going on. It's either they're bleeding, right? This is an actively bleeding patient, and then kind of bleeding and clotting. And that's really what you're alluding to earlier. That's your physiologic demonstration of stroke volume variation, because every time you give those patients a little bit of fluid, they seem to look better for a brief period of time. And
as the medical intensivist, that, if your fluid bolus buys you 10 minutes to walk away from the patient and then you get called right back, these are the things that, got to come to your mind. You're not,
as opposed to that patient. Now let's take the patient, like exactly the one you've been mentioning throughout our talk today, that stiff or non-compliant or poorly functioning RV. Those patients, you can give fluid, it doesn't seem to do as much, almost until you get into like a Fontan physiology and make it a passive conduit. But they're going to be much less responsive.
What we want to do is kind of begin to think about how we're monitoring, how we're doing this, and what our protocols sort of look like here. So as we're thinking of, is kind of the surgeons and I are deciding how we're going to monitor this patient through their procedure and then coming out into the ICU. One of the things that we will do, of course, is we start with the patient. What is their history? What are their comorbidities? How much risk do they have going into the case? Some patients are very straightforward, and we are almost certain we're going to be able to do them, with non-invasive or minimally invasive measures, kind of all the way through the case. Some patients, they are very sick. They have an EF of 25% and they have a bad RV, and you're doing a couple of valves, and for sure you're going to need, a swan and probably multiple ways to monitor the patient throughout the case. And then also some of this is your culture, where you are. And I don't want to downplay that, because we're not trying to replace one dogma with another here. Your culture, where you are, what you are good at, the experience of your providers and your team determines what you should do, at least at this point. So we want to become facile. We all want to learn. We all want to grow, but your local culture and kind of where you are building from matters here as well. Okay. So we're going to show this a couple of times, and I think we've already begun to think through this and talk through this. But really, as we think about kind of hemodynamic monitoring across cardiac surgery, I'm not sure, maybe with the exception of like the laboring and delivering patient, there is no other time in humanity where you go through this many different physiologic states this quickly. From pre and post induction, to getting on bypass, to having the surgical procedure, to coming back off pump, to closing the chest, to moving to the ICU, you've got very unique conditions in each one of these. And that should prompt us to monitor patients differently in each one of these settings, okay? It would be very counterintuitive to say, I've got one tool and it works for all of them. Why would we think that? That's really counterintuitive. So we need the right tool. We need the right way to monitor across the continuum of care. So, you can see some of the suggestions or thoughts up here. We're going to use our TEE as we induce. We're going to get that down, and we're going to be watching the heart. Okay. The Swan-Ganz catheter is great as we kind of are going into this, pre-induction state. However, as we go on to bypass, the Swan means very little. Okay. It's going to be a little bit less good during that time where we're on pump. Coming off pump, we know there's a lag, okay, with the Swan. So maybe its utility is not particularly good there. We look at cerebral oximetry and, the ability to monitor the patient. That may have less utility on either side of being on bypass, but while you're on bypass, looking at tissue level, brain, tissue oximetry is critical, is really important. Being able to see what our end organs are seeing during that time where the OR is so quiet. And then using a flow tracker, a non-invasive monitor, really has a nice utility there as we come into the ICU, and maybe the patient doesn't need all of the invasive things anymore, but we can use that to help us. So right tool for the right patient at the right time is really what we want to preach here, and thinking about what each tool can give us is really imperative. Move to the next slide. So this is a kind of a version of the protocol that we have adapted to use at WakeMed, and really all of the ones that you were going to see out there are fairly similar, but it's allowing us, as the patient rolls into the ICU, we are thinking about, okay, what do we need to do to optimize this patient's hemodynamics? And the way that we're doing is we're looking at stroke volume, cardiac index, and MAP. Okay, we're using kind of flow and pressure along with some resistance indices, kind of tracking that in the background. We're giving fluid. Does the stroke volume increase? Yes or no? If the stroke volume doesn't increase, are we optimal? Well, maybe. It depends. If our index is still below target or our MAP is low, that's prompting us to either start an inotrope or a vasopressor, and sometimes both, depending on the situations. But we're flowing through this algorithm continually. And when we have patients who are not doing well, we always go back to this algorithm to help us. And we can do this either with, it's designed initially for patients with a minimally invasive monitor in place, but we can use this with the Swan as well, and occasionally we will. Use it there, depending on the patient. So we use this kind of goal-directed approach just to continually assess and reassess the patient until they are stable. Next slide.
So I think here I'm supposed to talk a little bit about what we do at Centennial. and talks in terms of what we do for goal-directed therapy. And it's very similar. I think one of the things I want to stress is that again, Dr. Fox and I are not here to create a new dogma. We're really here to talk about some new approaches, but really that the centerpiece of all of this is becoming more consistent in reducing variability and then using these new tools that we have. And so one of the things that we decided in our center is that go ahead and start using the continuous cardiac index monitor, also the EV1000 or the newer models with the placement of the A line. So now you already have a baseline understanding of kind of where you are with your patient. Then immediately start the goal-directed therapy after chest closure. And the reason we chose that time point is because we are a pretty TE heavy institution. So we have pretty good data on the heart going into surgery and then during the whole peri-surgical period. The other thing that I've really moved to doing and making sure that goal-directed therapy is being adhered to during the operation, Dan, is that with our perfusionists, I've really worked with them on goal-directed perfusion. So now our whole algorithm of when we transfuse a patient and what flows we run is more dependent on DO2. So we do DO2, delivered oxygen calculations on every patient, because just as you alluded to earlier in our discussion, it's really about tissue oxygenation. And that's what we want to optimize. So that I've been much more focused on that number and that metric with our perfusionists. And I think I've seen some improvement in things, particularly on the AKA side. So the other point I want to make is bullet point number 2, enter the patient demographics correctly. Can't stress to you how much all of this technology depends, garbage in, garbage out. If you don't have their BMI or BSA appropriately calculated and entered, there can be huge errors in the outcomes in what you get. So this is a kind of a key sine qua non kind of point. Once you get there, what we now look at is understanding what our target cardiac index is for the patient. Again, going to smaller aliquot boluses. Before both you heard Dan and myself say 501 liter boluses were kind of standard. We really have taken that down to 250. We have a split point on how much crystalloid we do. Then when we move to colloid, how much colloid we do, and then how much back to crystalloid. And of course, in all of that mix is looking at transfusion as a possible necessary tool as well, depending not just on the absolute hemoglobin or hematocrit value, but also again on some concept of how the patient's doing in terms of tissue oxygenation. And then we look at stroke volume variation. Just like you see, if there's a 10% or more, we can repeat those boluses. If it's really not, and you're seeing, might consider pacing or other modalities, and then if still don't see the result, then looking towards other types of modalities like inotropic agents or vasoconstrictors. So that's really how we kind of do things. We kind of discontinue the monitoring once you have a very consistent, stable cardiac index. The patient is ambulating and has basically come off drips, basically the patient that's ready to move to telemetry.
I think that's great. And it's really a beautiful kind of eloquent description of, the way that we should be thinking. And one other side point about this, really any sort of goal-directed therapy, in my experience, is it empowers our nurses in an amazing way. And to watch our experienced cardiac nurses have the ability to kind of run through this algorithm, make decisions, use, kind of data to help them, at the bedside there. It is really empowering. And, our nurses are among our biggest resources, if not our biggest, in caring for these patients. And, allowing them to kind of take the lead in this and really be kind of champions for physiologic goal-directed therapy has been a huge win for us. And I know it has for you as well, but really, really important stuff for all of us.